Good evening, doctors. Welcome you for the Iron Talks 9 p.m. show with Dr. Sanjay Karla. And today we have a special guest from Mumbai. Before I invite the special guest for taking over the session today, I introduce to Dr. Sanjay Karla, which doesn't require any uh, introduction because Dr. Karla is a famous endocrinologist, graduate from All India Institute of Medical Science, New Delhi. He's a past president of Endocrine Society of India, and he's a president-elect of South Asian Federation of Endocrine Society. He's a board member of International Society of Endocrinology and is a president of Indian Professional Association of Transgender Health. With this, I welcome Dr. Sanjay Karla, and Dr. Sir, your session is yours.
Thank you, Mr. Basu. Thank you to the entire FDC team and warm welcome to everybody who is logged in today. We've been talking about iron, we've been talking about anemia for the past many weeks. We've focused on various aspects of this condition, this syndrome. Most of the questions that we get from you are related to therapy, to pharmacotherapy. So today we thought we'd have a session specifically on pharmacological management of anemia. And for this, a warm welcome to Dr. Mangesh Triwaskar, Secretary, Honorary Secretary of the API, Association of Physicians of India. Dr. Mangesh, warm welcome to Iron Talks.
Thank you, Dr. Sanjay. Thank you very much, and good
Sir,
evening to
we have a
everybody.
question for you. What is the similarity between a secretary and a physician? A secretary of API and somebody who is managing anemia. Any
Oh,
similarities?
the most commonest similarity I can find it out is this, that both we being the physicians and being the secretary, encounter anemia in their day-to-day life, and as far as the questions and the problems which are concerned, which are so much at mass level, that you are addressing there specifically. And same way, secretary of any association would do the same job for an association, especially dealing with these common day-to-day problems and management, not only at the administrative level but also at the day-to-day connect level with the all the members of the society. So I could immediately think about this. I hope you are expecting something else. So if at all, then you
So
must answer that.
that's right. What you're saying is right. And lots of questions coming in already. But Dr. Lakshmi Narayan and Dr. Balu, we acknowledge your questions. Perhaps we can request Dr. Mangesh to talk about the pharmacotherapy of diabetes, of anemia first. If there are any questions left, we take them up after his presentation. And just like a secretary, a secretary's work is to serve. Similarly, a physician's work is to serve. And here we are serving the patient with anemia. So, Dr.
Right.
Mangesh, warm welcome once again. The floor is yours.
Thank you very much, Dr. Sanjay, and good evening, everybody. And thank you, FDC team, for such a wonderful, wonderful opportunity. And as you know, I had logged in a little before you, and I could hear Mr. Basu praising you so much. And I thought in my mind that that when I will be probably able to reach what Dr. Sanjay has reached in his curriculum. And it's always a pleasure and a privilege to be associated with you. So thank you, everybody, and most importantly, uh, thank you the entire FDC team. I'm trying to share my screen, so please allow that to happen. Okay, and then I'll start. I believe is my screen visible, Dr. Sanjay? Is my
Yes,
screen
yes,
visible?
it is perfect.
All right. So good evening, everybody, and wish you all a very happy and a prosperous new year, which is going to come. And of course, belated very happy Deepavali. I hope you have enjoyed your vacations. And whenever there is a name of Dr. Sanjay Kalra joining hands with people like us and including pharmas like FDC, probably the response is expected. Now, as Dr. Sanjay has already spoken to you, we have been discussing about the management of iron deficiency anemia and the anemia in last 5 or 6 sessions before me. What in next 15-20 minutes is that I'll try and attempt to decrypt the management. Before I do that, once again, I put on records my absolute appreciations and thanks to Dr. Sanjay Kalra and the entire team MDC. This you are all aware, and it has been told to you that these are the diagnostic criteria whenever you diagnose somebody with anemia. That if at all, and I being a physician treating more adult patients, I will probably try and focus on the adult population because you've been already addressed by a pediatrician been already addressed by an endocrinologist, a nephrologist, a cardiologist. Everybody has discussed anemia and the related challenges. So I'll try and focus as far as the overall management of anemia is concerned. So I'll skip initial slides. But a very interesting thing that I have found when I was preparing this presentation is how many red blood cells are produced. Do you have any idea every day? Or if I have to ask you every minute? Or if I have to ask you every second? And the figures that I'm going to show you are going to surely blow your minds out. Look at this. The production of red blood cell is around 2 million cells per second. That comes to around 120 million cells per minute. That comes to around 173 billion cells every day. You know how much is the global population? 7.8 billion, right? So you can imagine that 173 billion or 173,000 crore cells are produced every day. And this is, I'm talking about RBC. So imagine, how much is the workload your bone marrow is under to give us the hemoglobin of around 15.7 plus or minus 1.7 in men and 13.8 plus or minus 1.5 in women. And iron contains, they really get depleted to give us iron deficiency anemia, right? And majority of the iron content for men, the total body content is around 4 to 6 grams. That is the size of a iron nail. And in women it is around 2 to 3 grams, and most of the iron is distributed in the red blood cells in the form of hemoglobin. Small portions are in the form of myoglobin, and of course, there are few iron containing enzymes like catalase and cytochromes. And there are some store form of ions or storage forms of iron, which are ferritin and hemosiderin. Now, I'm not going to go into the details about this. Investigations have been already discussed. But before we actually go for the management or the pharmacotherapy, you must assess the patient for what stage of iron deficiency anemia he or she is in. Usually, you call it as a stage one when the iron levels are low, the stores are low, which is usually represented in the investigations by low ferritin levels. So, especially when the ferritin levels they go down below 30, and patients are asymptomatic, patients have anemia. Probably that is a stage one of the disease. In the stage two, there the RBC changes starts and the RBC size starts falling down, leading to microcytosis. And of course, along with that, the ferritin levels go down, but transferrin saturation also falls, and still the patients are asymptomatic. And whenever there is an overt, well developed or fully developed iron deficiency anemia, the hemoglobin, the hematocrit will fall below normal, the hypochromia also will appear along with microcytosis. And as the anemia worsens, the symptoms start appearing. Why it is important? Because that will decide about not only the modality of the treatment that you are going to offer to the patient, but also probably it will help you in deciding how to investigate these patients and how urgently you need to correct the hemoglobin or treat anemia. So whenever you approach an iron deficiency or a patients with iron deficiency, follow some basic rules. First, identify the criteria, whether it is iron deficiency anemia or it is additionally something else. So diagnose properly, identify the cause, because understand, no matter whatever the pharmacotherapy you give, if you do not treat the underlying disease, the therapy is not going to be successful and sustainable. Also, check out the possibility of a GI challenge, like in the form of malabsorption, which is one of the commonest cause of iron deficiency anemia. Rule out, most importantly, anemia of the chronic disease. Remember that anemia of the chronic disease and iron deficiency come hand in hand. Why it is necessary to rule out or appreciate the presence of anemia of the chronic disease? Because the correction therapies will be decided depending on the presence or absence of anemia of the chronic disease along with iron deficiency anemia. And of course, judge the severity, look at the patient compliance, economics, especially when it comes to the parental therapy, you need to really decide on that. What is the reference nutritional index, or what is also called as the recommended daily allowance for the patients as far as iron per day is concerned? In women, it is little higher naturally. They in the active menstruation phase of or age of 19 to 50. The usual recommended nutrient index of iron has to be around 8 to 14.8 milligrams per day, and for men it is 4.7 to 8.7 milligrams per day. Now there are few non-transfusional methods of improving hemoglobin therapy, you know, where you do not have to transfuse the patient or give blood transfusions. Number one is iron replacement in the form of either oral, IV, or intramuscular. Of course, concomitant B12 replacement, erythropoietin therapy, in rare occasions, steroids. Blood transfusions usually are discouraged in the patients of iron deficiency anemia alone. So the modalities of management or the modalities of iron therapy along with the dietary corrections are either oral iron therapy, parenteral iron therapy in the form of either injectable iron or the human recombinant erythropoietin you offer, and last but not the least are blood transfusions. So let's quickly talk about oral iron. Okay, usually the rule is that whenever you supplement oral iron or a oral elemental iron by around 100 milligrams, usually in the garden variety of anemia, especially iron deficiency anemia, you would expect the rise of hemoglobin by around 0.18 grams per day. But remember that iron absorption depends on lot of factors, including the bioavailability of the iron, the phosphate pyruvate deficiency or the presence, most importantly, worm festation, especially in the Indian subcontinent in children. Worm festation is one of the prominent causes of iron deficiency anemia. And of course, if the iron stores are poor, probably you need to approach the iron therapy in a little different way. So let's talk about oral replacement, which usually is in the form of three ways: either through diet or what is called as a native oral replacement, which is and the diet, the correction happens through the iron supplementation via heme form, that is the iron which is present in the non-vegetarian food, or the organ meat, which we call it as like liver or kidneys or heart or bone marrow, or the non-heme form, that means where you don't have meat as the replacement for the iron. So in the vegetable forms, in the fruit forms, whenever you are replacing iron, that is a non-heme form of replacement therapy. And of course, the therapeutic treatment either by the oral iron replacement or the medications, either orally or injectables. So quickly look at the oral iron preparations usually considered when iron deficiency anemia is usually the hemoglobin is mild to moderate. So whenever the anemia is mild to moderate or you are not in a hurry to correct anemia, probably the oral iron preparations are usually initially tried. Now, your slide shows the various iron preparations which are available in the market: ferrous ascorbate, ferrous sulfate, ferrous fumarate, ferrous gluconate, ferrous biglycinate, ferrous succinate, ferric citrate is also available now. And of course, the newer iron molecules, which I'm going to show you in next few of the slides, you'll realize that there are new oral iron therapies which are also available. Commonly used is usually ferrous ascorbate or ferrous citrate. The advantage of using ferrous ascorbate or citrate is usually it is combined with acid, and especially the ascorbic acid. Remember that if you really go back to the physiology or the iron absorption, you'll realize that iron needs an acidic medium for the better absorption, isn't it? In the ileum and the jejunum, where the iron gets absorbed the most, usually there is an and the oral form of most of the iron that goes through the food is in the form of ferric. So Fe3, it needs to be reduced to ferrous. So ferrous and ferric conversion has to happen, and that happens through ascorbic acid. And ascorbic acid reduces ferric ion to ferrous ion, which remains soluble even at the neutral pH and gets absorbed. And that is how the importance of acidic medium is necessary whenever you are supplementing iron therapy. But oral iron has some caveats. It has got a tendency, especially the older molecules that we used for the treatment, had the caveats like severe gastric irritation, belching, hyperacidity, diarrhea, constipation, worsening of the malabsorption, sometimes worsening of the irritable bowel disease. And of course, it also generates free radicals, especially in the patient, those who are very sick or acutely sick patients. sometimes it can be dangerous, or to replace oral iron during the presence of acute inflammation. And the beautiful example I can give you is the anemia correction during COVID times. Remember that, whenever there is an acute infection or an inflammation which is on, first treat infection, bring down the inflammation, and then supplement the iron therapy, especially when the patient is unstable, because otherwise iron is known to worsen the infections. Okay. Then what are the latest advances in the oral iron therapy? They are developed with the aim to overcome the common side effects of the oral iron tablets that we discussed. Also, they will help you in improving the compliance. They will eradicate iron deficiency at much cheaper rates, and also they are very easily administrable even on the OPD basis or under home therapies. So, what are the recent advances which are iron polymaltose complex pills which are available, a compound which is derived from maltose and sucrase combination of iron. Usually, it is a macromolecular complex and has got higher content of iron in comparison to the regular ions, those were available initially in the market or commonly available iron pill. And the free iron content is less, hence they are much more gastrointestinal friendly, or they do not cause too much of gastrointestinal toxicity. Also, there is a carbonyl iron for the oral iron therapy. The biggest advantage, even over the polymaltose complex, is this, that it is 98% pure form and it is a micromolecule. So, better absorption, less side effects, black stools are less, they are high, and the sustained absorption is there, nearly 70% get absorbed. Overall, if you really see, whenever there is a oral iron replacement by the previous generation oral iron therapy, the iron absorption is usually in a tune of around 20 to 30%, not more than that. And here the iron absorption goes to around 70%. So it causes a good rapid rise in the hemoglobin, and there is a wide margin of the safety, and possibly because there are fewer GI side effects or lower GI side effects, the patients, they adhere to it or they are compliant. The makers of the iron preparation from the house of FDC, which is new, it is a citrate preparation which is available, and so the ferrous glycine, ferrous calcium citrate, ferrous succinate is also available as the other oral iron preparations. Talking about the parental iron therapy, there are two modalities which are available, either through an intramuscular form or an intravenous form. Remember that whenever you use a parental iron therapy, in comparison to the oral therapy, obviously there is going to be a little rapid or more faster rise in the hemoglobin level. So the hemoglobin can rise by around 0.21 grams per cent the moment you replace around 100 milligrams of elemental iron through the parenteral route. But there is the most important caution for all of the viewers is this, that both intramuscular or IV iron can in select situations induce anaphylactic reactions. So most importantly, whenever in your day-to-day clinical practice, whenever you want to give iron therapy parenterally, always do the test dose, preferably avoid in the OPDs, or if at all you need to treat them in the OPDs or in the daycare center, have all the facilities to actually manage an anaphylactic reaction, and then only probably try an parenteral iron therapy. So the advantages of the intravenous iron therapy or the parenteral iron therapy over the oral iron therapy is that even in the non-compliant patients or the patients those who do not tolerate any form of oral iron, probably are best benefited with the parenteral therapy. It causes a rapid rise in the hemoglobin, best used in second and third trimester of the pregnancy, cause minimum GI side effects. It is one of the choice of the therapy when iron deficiency anemia exists along with the anemia of the chronic diseases. And the patients with the kidney disease or with the erythropoietin therapy, they are best treated with intravenous iron rather than the oral iron. There are few disadvantages of the parenteral iron therapy, especially intravenous iron therapy, is that they are expensive in comparison to the cheaper oral ions, will call for the hospitalization or at least a daycare observation, and also the anaphylactic reactions are very, very common. Commonly, The Ganzoni formula is used to calculate the iron deficiency, and I'm not going to read the formula that is there on your screen, but generally by rule, usually if the patient is below the weight of 35 kgs, or generally IV iron which is necessary for the patient is usually 500 milligrams. Do not cross 500 milligrams at one time, and especially even though the hemoglobin is less than 10, if the body weight of the patient is less than 35 kgs, these do not cross the level of 500 milligrams in one infusion. And of course, depending on the weight per kg weight, you can calculate the iron need and you can replace intravenous iron accordingly. What are the preparations which are available? Beautiful preparations are available. Ferric carboxymaltose, iron isomaltoside, ferrumoxetol, HME dextran, that is high molecular weight dextran, low molecular weight dextran, which are the older preparations. Sodium ferric gluconate complex, which is also available. And of course, iron sucrose is also available. But remember that most important is that please do not use this without the preparation to treat anaphylactic shock. Use the test dose, and of course use all the facilities or have all the facilities ready to treat anaphylaxis if at all you are deciding to administer iron in a daycare center without hospitalization backup or in your OPD practices. Always, always, always remember this in your day-to-day clinical practice. Quickly, these are the differences between the ideal iron preparation, iron dextran, iron sucrose, and iron ferric carboxymaltose. All are beautiful, all can be administered depending on the compliance and the cost of the therapy and the availability of the molecule. Always remember that there are some special populations in whom you should be extremely careful. Parental iron is not indicated in the first trimester of the pregnancy, especially I'm talking about ferric carboxymaltose. In the second and the third trimester also, always give it with the care because it can induce an anaphylaxis reaction. Lactation children usually are not studied, so preferably avoid the ferric carboxymaltose injection. Hepatic dysfunction, acute and chronic infections, I have already told you about that. And of course, in the presence of cancers, in the presence of the anemia of the chronic disease, if the ferritin levels are above 100, there is a clear contraindication for iron therapy. Fewer times we use combination therapy of iron B complex. Sometimes B complex iron plus transfusions are necessary. Sometimes iron B complex plus erythropoietin is necessary. I will not be discussing that in details, but I have already told you that whenever the presence of anemia of the chronic disease is there along with iron deficiency, the best form of therapy is IV iron or the parenteral iron therapy in comparison to oral iron therapy, because in this scenario oral iron is not going to get absorbed because of a very high hepcidin level. So the ferroporotin, which is the only known iron transporter from intestines to the transferritin and the liver storage, is absolutely inhibited by high levels of hepcidin, which is the only hepatic regulator, for the transport of iron from intestines to the bone marrow or to the stores. You need to keep on assessing the therapy whenever you the impact of the therapy whenever you are managing these patients. So always keep an eye on CBC. Usually you should expect a rise of around 1 to 1.5 grams per deciliter at the end of 10 days. And of course the improvement of the performance scales, the relief of the symptoms. Always keep a watch on the ferritin levels, especially why the serial ferritin levels are important. Basically there are few patients, especially when you are managing anemia, where you are not very sure whether the patients are going to be iron responsive patients to the, especially to the oral iron therapy. So generally the serum ferritin serial levels are done. How they are done is usually, the baseline serum ferritin is done and then the oral iron therapy is initiated, and after 3 days again the serum ferritin is estimated. If the serum ferritin goes up by around 30%, that means that these patients are iron requiring patients and will respond to the iron therapy beautifully well. So serial serum ferritin estimations can be necessary sometimes. And of course, do keep a watch on the other causes, especially if there is any GI loss. The drugs like aspirin, which can induce the micro bleeds inside or malabsorption whenever you are managing. Lastly, importance of not giving iron therapy in the presence of acute infections, in the presence of cancer, or if the patient has ferritin levels of above 100 nanograms per ml, please do not give iron therapy, and especially iron therapy parenterally, because it can induce what is called as a toxic Fenton reaction, which can be life threatening, and it is usually an acute systemic inflammatory response to the overall overload of the iron, which gets deposited more into the reticuloendothelial system rather than getting deposited in the liver and the bone marrow. So to conclude, friends, we need to always assess a, iron deficiency whenever you are treating the patients of anemia, because that is the commonestly encountered nutritional anemia. Every specialty faces anemia, so every specialty has to learn to manage anemia on the day-to-day basis. But the primary care physicians or the generalist need to be aware, because these are the people, those who have the first contact with the patients. They can diagnose it correctly, and if you are able to diagnose that correctly, it is easy for all of you to manage them at the OPD basis, which will be beneficial not only to your patients but to you all. And of course, we need to understand that whenever you are treating the patients of iron deficiency anemia, always along with the iron therapy, you should treat the underlying cause. And also, sometimes in some select scenarios where you need to use a combination of erythropoietin, replacement of the B12 or the folates, preferably, should be considered in select scenarios. Avoid transfusions as far as possible. If at all you need to give blood transfusions, avoid whole blood transfusion, preferably. And there are other aspects of the blood transfusion which we call for a separate session. So let us not discuss that here in details. And of course, keep on assessing your patients as far as the response to the therapies is concerned, because you need to ultimately have a goal to improve hemoglobin. I'll conclude by a very, very great saying by one of the great souls that we had, Dr. APJ Abdul Kalam. The greatest reason for the failure is not ignorance, it is the illusion of knowledge. Thank you very much. I appreciate your, I would say, uh, presence and sparing of the evening times. And of course, I would be very happy to address your questions if I have not confused you adequately. Thank you very much.
Thank you, Dr. Mangesh. Lots of questions and comments and appreciation for your talk. Thank you for making things simple and also for reminding us that iron should not be taken lightly. It is a very
Yes,
strong metal after all, and it
yes,
can cause side
yes,
effects.
yes,
But this
yes.
wonderful comment from Dr. Javed Iqbal Khan from Srinagar,
Okay.
really
Hi, Dr.
beautiful
Javed.
comment actually. Yeah, really
Yes.
beautiful. Uh, any woman or any man for that matter, you think of whether to choose silver, gold, or diamond. But
I would,
the most
I would
important
choose
metal is iron, actually,
iron.
elemental iron.
Yes, that is
Yes,
beautiful. Yes, truly
that is a
beautiful.
beautiful way of putting things together.
Yes, yes.
Lots of questions. Dr. Lakshmi Narayan Jat says, severe anemia in persons with diabetes, do we treat the same way or do we think of something else as well?
No, addition. Whenever you have a coexisting disorder, is Dr. Lakshmi, right? So,
Hmm.
whenever there is a coexisting chronic metabolic disease, always, be very careful in diagnosing, whether it is just an iron deficiency or there is also an anemia of the chronic disease or anemia because of diabetes. Remember that diabetes can also cause anemia, and which will require a different approach.
Yeah. Dr. Vinay Desai shares a diabetic patient
Yes.
description. 58-year-old gentleman, 70 kg. Fasting is 221. Post lunch is 222. So the basically it's a fasting hyperglycemia which is not getting
Hyperglycemia.
controlled. HbA1c is 12. Patient
Oh.
is already on Basalog 25 at night,
Hmm.
Novorapid 8 units 3 times a day. So
Hmm.
we can increase the insulin dose, but patient is also on vildagliptin, dapagliflozin, and metformin. Metformin has gone up to 1.5 gram. Still, HbA1c is high. Patient is better than before. Earlier he was on insulin 50/50, but still we are not able to get the fasting glucose down. So what do we do?
Oh, that probably you. I think Dr. Sanjay, you should answer this as far as the math. Now, what do you want us to address, Dr. Vinay? Is it that you are worried about the diabetes part of the story or an anemia part of the story?
Maybe
Diabetes
both.
part of the story, probably Dr. Sanjay is the best person to answer this.
So, Dr. Vinay, see, you are doing the right job. There is no mistake in the prescription. Some things we can do are we can change the euglargine 100 to euglargine 300, glargine U 300, or to degludec, which are ultra long acting insulins. You can also think of adding a light sedative at night. So, ask the patient if the patient is sleeping well. So, what I speak in my OPD is that fasting, the daytime glucose, postprandial glucose, is more closely linked with lifestyle, daily lifestyle, diet, and exercise. The nighttime glucose or fasting glucose is not so linked with daily lifestyle. But actually, the thing is, if at night you are a daily shift worker, you are drinking a lot of alcohol, you're not able to sleep well, you have bad dreams, then certainly fasting glucose will be high. So we can change to ultra long acting. We can add a sedative, alprazolam, clonazepam, whatever you feel like. One drug which I use is lemborexant, which is a non-addictive
Right.
uh, sedative. The trade name is Devigo, 5 milligram. But do look for hypoglycemia also in this patient. So no harm in doing a 3 a.m. glucose. So this is one aspect. Coming to premixed, let us come back to that later, Dr. Vinay. In the meanwhile, Dr. Iqbal Khan says, whatever you are saying, whichever oral iron salt is tolerable, patient should take that. And every woman from menarche to menopause should get
Yes.
iron supplement at least 7 to 10 days in a month for replacement of physiological blood loss. So,
Correct.
do you
Maybe
feel
a
this is
good,
correct, sir?
yeah, maybe a good comment, but also always remember that the moment you cross the hemoglobin of 11 grams per cent, usually the benefits of the therapy they go down or they are not as proportional whenever there is an anemia situation on hand. So really we be watchful on the hemoglobin of the patient just because the women are in in the I would say in the menstruation period, or during that 7 days that you are talking about. It's not just that because they are in the in the menstrual phase they should be replaced or they should be given iron. Not necessary. Always remember that look at the hemoglobin and the signs of iron deficiency. If at all they are there, then probably you have the reason to replace.
And
and
as
and in such,
public,
rather than the supplementation, Dr. Sanjay, probably additionally, probably the nutrient based iron replacement could be also probably tried in the patients to avoid such kind of a scenario, especially in the women.
iron-rich foods. And
Yes.
Dr. Javed also shares a public health message. This is for public health because two-thirds of all Indian women are anemic. So 100 days in a year, you should take an iron supplement. So that is
Yes.
also a nice way of remembering 100 days per
Yes.
annum.
Yes.
One question Dr. Khan has, that is, when you give parenteral iron, like maybe ferric carboxymaltose, full dose, you
Right.
give 1 gram or you give
Yes.
500
Yes.
milligram, why does
Yes.
it take 3 weeks for the pharmacological effect to come?
Hmm.
But with
A good.
blood transfusion, you get the effect within 15 minutes to 24 hours.
Absolutely. Absolutely. So the answer lies in your question, sir. Whenever you are transfusing blood, actually you are transfusing direct iron, in an already readily functional form. Because that iron is an integral part of hemoglobin, correct? So even though you are injecting parenterally intravenously, that iron has to still attach with the uh, uh, transferritin. Then this transferritin will take it to the bone marrow. The RBCs need to pick that up. The hemoglobin has to have a binding with it. The new RBCs are getting formed. The older already preformed RBCs will not take it. So all these things will require at least a 10 days time to couple of weeks time. And that is the reason why whenever you initiate the therapy, even though in the initial phase you may feel that there is a good rise, but usually the assessment ideally has to be done after 10 days to 2 weeks. So there is no point in calling the patient for reassessment within a week's time, while you may not get the actual potential effect of the drug whatever you are given.
And what Dr. Javed says is right. 1 unit of blood contains 200 milligram iron.
Correct.
Ferric carboxymaltose, you will give 500 or 1
I
gram.
mean, yes.
Like Dr. Mangesh said, it takes time for the iron to get incorporated. Another thing we should remember is just like platelets do
and
not have
and most importantly, Dr. Sanjay, is this that Not all iron that you inject lands up into bone marrow. Not all iron that you inject lands up into the storages. There's some part of the iron which is also being taken up by the other systems. There's some part of the iron which has been also taken up by the reticuloendothelial cells, and especially that holds true whenever there is a chronic metabolic disorder or a malignancy, or somebody is on with chemotherapy or in an acute infective phase. Really, the iron behaves in a different way at the different scenarios. I'm sorry to have interrupted you.
No, that's right. In endocrinology, we have this hungry bone syndrome. So, like that in
Right.
anemia, you actually have hungry spleen syndrome. So, sometimes
Yes.
the spleen eats up all the iron.
Yes. Yes.
We should also remember that just like platelets do not have nuclei, RBCs do not have any mitochondria. So,
Correct.
mitochondria are the powerhouse of the cell. There is no mitochondrium in the RBC. So, that is
Yes.
another reason why, this energy based thing is a bit slow with RBCs. So,
Yes.
ferric carboxymaltose will take some time. One very good suggestion coming from Dr. Javed and Dr. Mangesh has also alluded to that. Each and every iron can have side effects. So you should transfuse only in hospital setting, not at home, and first aid facility should be available. Do not take it easy. And
Yes.
he just wants you to reinforce this. Can you discuss this, sir?
Yes, absolutely. And as you rightly pointed out, Dr. Javed, it is necessary for all of us to understand, and all our friends must understand that this, especially whenever you are talking about the parental iron therapy, you need to be always very, very careful and cautious about acute anaphylactic shock or an acute allergic reaction. And sometimes in the special populations, you may have the challenges of dealing with this kind of a scenario. And if at all there are any challenges or the complications prior, not only the patient's life is in danger, but your career is also in danger. So be little careful.
And we welcome into the discussion Dr. Apurva Biswas, Dr. Anshul Singh. Dr. Anshul Singh is a diabetologist in Chhattisgarh.
Yes, of
And
course, I
Dr.
know
Ashok.
Dr. Anshul. Yes, yes,
Coming back to Dr. Vinay Desai's question. So, this fasting glucose is not getting controlled.
yes.
How do we approach? Number one, rule out midnight hypoglycemia. That is Samogi phenomenon. If you can do only one glucose, you do it at 3 a.m. If you've ruled that out, then you rule out sleep disturbance. So, rule out obstructive sleep apnea, insomnia, use a soft sedative. If even that doesn't work, then you look at the properly. Is the pen correct? Is the vial and needle, are they matching each other? Are the cartridge and pen matching each other? These kind of things. And if all that is proper, then you shift to an ultra long acting insulin. Then for hepatic pathology, this is the way I would work about it. And
Yeah,
Dr. Vinay, do let us know what the results are next time.
yes. And one more thing about his questions, Sanjay sir. Sanjay sir, one more part of the question. He has asked, whether this
Yes,
patient can be shifted to a premixed insulin rather than, this basal bolus that he is on with.
premix.
So, would you recommend this patient
Yeah.
to go on the premix insulin?
So do not worry. We will not give you 4 doses forever and ever. The moment your fasting comes down to near 100, then we can give you a long-acting insulin plus rapid-acting insulin together. So you can give a biphasic aspart plus degludec, and that should work.
Correct.
You can tell
Right.
the patient to wait for about 20 days, and in the meantime, you can give him I'm very sure in these 20 days you can give him
I think there are some net issues, Sanjay sir, on your part.
we were talking about reasons for anemia in diabetes.
Correct. So we know that the commonest cause for anemia, usually because of the chronic disorders, is diabetes, and we are all aware about it. So if you really ask me what are the mechanisms by which you can get anemia in diabetes, number one is chronic hypoglycemia. Number two is the chronic kidney disease, which can be associated, which can be a subtle disease, but it can be a part of diabetes. We all are aware about it. Chronic inflammation is one of the responsible factors. Increase in the advanced glycated products or the end glycogen products which get deposited in the various organs can be a cause. Then, of course, diabetic peripheral neuropathy and autonomic neuropathy can be a cause. We all are aware that diabetes is a chronic inflammatory situation. So, there is always an excessive oxidative stress and the reactive oxygen species is high. And now that does what? That because of this chronic inflammation, overall the RBC lifespan goes down, the abnormal RBCs are formed. And quite a few times, along with the autonomic neuropathy, there could be malabsorptive disorders like Crohn's, which can be there, or sometimes because of the use of ARBs or metformin, there can be a B12 deficiency, which add to the chronic anemia additionally. And this will overall lead to what we call it as, the reduced erythropoietin production or the function or the effect which will ultimately lead to anemia and diabetes. I hope I have understood your question correctly.
Hmm. And the treatment will be based upon the cause, actually.
Correct.
Dr. Anshul has a very good comment. This is for the patient who is not getting control with fasting. Rule out non-compliance with insulin. And
Right.
so many times in my OPD also, patient says, I'm taking insulin. But then it turns out they were not taking the basal insulin because it is more expensive, or they are not taking the lunchtime insulin because it is inconvenient for them,
Yes.
or both of the above.
Correct. Or
One
or
question.
probably Dr. Anshul, it could be also additionally, the erroneous dosages or not administering the needle challenges, the
Hmm,
cartridge challenges, all these
yeah.
pain challenges, everything can be there.
And some other reasons which are not limited to Haryana, but which can occur anywhere in the country. Too much of alcohol at night, too much of full cream milk at night.
Correct. Absolutely
So
correct.
that, yeah, that can also increase the fasting glucose.
Right.
One question is, when I've initiated oral iron therapy, this is again from Dr. Singhai, when should I repeat ferritin test? When should I repeat hemoglobin test?
So ideally, whenever you have initiated for oral iron therapy, and especially if the anemia is usually severe, moderate to severe, that means hemoglobin is around less than 9 or 8. Really, the patients are good responders, and maybe that really at the end of 10 days you may expect that you can repeat. Ferritin can be repeated little more earlier or more frequently just to know whether the patient is going to be adequately responding to the therapy. Otherwise, you don't have to really repeat ferritin again because it's not going to give you any additional information unless and until your hemoglobin does not rise to what you expect of your therapy. Then probably you may have to repeat the ferritin for the diagnostic cause. But as far as the monitoring cause, probably hemoglobin estimation is quite adequate. Maybe possibly the CBC, additionally, if your pathologist is good enough or your laboratory is good enough, will also tell you that probably that anisocytosis is getting disappeared, the microcytosis is getting disappeared, the hypochromasia is also getting disappeared. So these are the features which will tell that the patients are recovering. Even the simplest thing is what we call it as the red cell distribution width, which gets usually shifted to right or increases, will start coming down towards normal. So these are few of the parameters that you can see rather than doing a ferritin. Okay.
So simple things. And thank you, Dr. Mangesh, for sharing these insights.
Yes.
Dr. Vijay Pandey has a question. This is related to diabetes management. If the person has anemia, a very low hemoglobin, will that hamper the accuracy of fasting glucose, hamper the accuracy of HbA1c?
Uh, you know the best answer. Usually, HbA1c can be yes, and especially in the severe anemia situations and iron deficiency anemia, yes, the HbA1c can be disproportionate, and of course, sometimes it can be erroneously high, and the fasting and the prandial glucose, I don't feel so they get really affected unless and until there is a severe anemia causing a hemodilution or the compromise. Anything else, Dr. Sanjay, to guide?
That's fine, like you said. And thanks to you from Dr. Gajanang Sanap also. And I apologize that there seems to be a lag in my connection.
That was
So,
initially there. That was there.
Dr. Vijay Pandey says, is there any relationship between iron supplementation and protein intake?
Ideally, the oral iron has to be best advocated empty stomach. Surely not to advocate or administer it with calcium preparations or the dairy products,
Hmm.
and preferably empty stomach. Use it. Proteins, again, it will again the same interfere. Food interferes with iron absorption. Remember that. So it is necessary for all of us to understand.
And also greetings to you from Dr. Muhammad Suhail, who is from Aurangabad, Maharashtra.
Hi, Dr. Mohammed. Hi. Good
It's a
evening, sir.
strong Maharashtra team here today. Shagufta Yasmin is also logged in. Thank you for
Oh,
being
hi,
with us.
Shagufta. Shagufta is here in Mira Road, next to me, practicing.
So that is Team Maharashtra at work today, and also Team Haryana, because we have Sunny Grover Saab from Haryana here.
Yeah. Hello,
One
Sunny sir.
question, one question coming from Dr. DNA. This is erythropoietin. What is the role of erythropoietin in anemia? What is the role of erythropoietin in diabetes and anemia?
Oh, fantastic question. Erythropoietin per se is a beautiful subject to talk about, to be very honest. And I'm sure Dr. Manisha, you must have heard her on the first lecture. Well, she must have discussed erythropoietin in details. But remember that erythropoietin, how erythropoietin works. It actually stops the phagocytosis of the newly born new RBCs or the new baby erythrocytes which are getting formed from the macrophages and the attack from the WBCs, and it helps in maturation of the red blood cells. And of course, we all are aware that erythropoietin is also necessary for the better hemoglobin formation, for sure. Most importantly is when to use it and when not to use it. This is extremely important to understand. Now, there is a good amount of data which is available, and a very interesting study which is also incidentally called as ACCORD, but it is not a double C, it is an ACORD study which was done, where they looked at the use of erythropoietin when the hemoglobin is above 13, and they found out that there are no benefits when erythropoietin is given when the hemoglobin is around 11 and above. Of course, in the patients of diabetes, erythropoietin or the recombinant erythropoietin molecules which are coming, in the market, they are pivotal, especially whenever there is an anemia because of diabetes. It's quite possible that there is a kidney element to it. And the best part is this, that especially whenever there is an additional kidney involvement, always remember that anemia presents much earlier and very, very rapidly in comparison to the actual kidney existent disease. So we all are aware that the
We
EGFR
have
disproportionate. So there is a dyssynchrony between the fall in the EGFR and the fall in the HbA1c.
we have a lot of questions coming in on diabetes and on diabetic kidney disease today. So I would
Yes,
like to take the opportunity to remind everyone and request everyone. Of course, every Sunday we meet each other at 9 p.m.
yes,
Our theme is diabetes essentials, but currently we are working on iron talks for the next
yes,
few weeks as well. On the
correct.
14th of November, which is World Diabetes Day, we'll be having a special session with Dr. Om Ganda. He's
Oh,
a consultant
fantastic.
diabetologist from the UK, a very senior teacher, very renowned teacher. And what he has told us is that he is preparing some new content specifically for our audience, for the Indian audience. So do remember to log in on the 14th of November and let's badger Dr. Om Ganda with the toughest questions
Yes,
in the world. So
yes,
let's
yes.
learn from
I
each other.
agree. I agree.
Coming back to anemia from Dr. Vijay Pandey, what about folic acid? We are speaking of iron. Is folic acid not necessary anymore in diabetes in
No, no, no,
anemia
no, no,
management?
no, no. It's not that. It's not that at all. We are talking about iron replacement therapy and all that. Folic acid is pivotal, and I have also talked in my talk, that combination of sometimes B12 folic acid is necessary, and that forms a technically a complete form of a iron polypill. You can say an iron polypill, where which will have the iron, the folic acid, the mecobalamin, maybe probably additionally you can have the cysteine. Given together will have a much better absorption of iron. So folic acid cannot be ruled out, and quite commonly you get mixed anemias. Like, it's not necessary that pure iron deficiency, you know the B complex deficiency, the folates, they differ. So you need to understand that it's always a mixed nutritional anemias. It's not just a one element deficiency.
It's like Dr. Javed Iqbal was talking about the public health message: 100 days of iron in a day, in a year.
Yes,
So it's not
Yes,
only iron, it's the folic acid and B12 also. And
correct.
we speak of FDCs, fixed dose combinations in diabetes and hypertension, but actually the first fixed dose combinations were from anemia management only.
Anemia management. Yeah. Nutritionals or nutraceuticals were the first fixed dose combinations.
One last question, Dr. Mangesh, if you allow. This is from Dr.
Yes.
Khan again. Role of sucrosomal iron in your experience. He
Wonderful.
finds it very safe.
Yes, it is extremely safe. Sometimes I found it little better, as far as the incidence of anaphylaxis and tolerance is concerned. But it's quite comparable to ferric carboxymaltose, and it's also equally effective. And
Yeah.
maybe possibly that it requires little lower dosages in comparison to ferric carboxymaltose for the iron replacement therapy.
One other advantage I've seen is there is no GI disturbance and there is
Yes,
no blackening of stool. So
correct.
many
That
times
is
what
whenever you give
happens,
orally.
yeah, with the conventional iron, if you forget to tell the patient gets black colored stools and he comes back rushing that I've got piles now and you
Yes,
caused bleeding.
yes.
Uh, Deworming, is that important part of
Absolutely,
anemia?
absolutely. You have hit the nail on the head. I spoke about it. Always remember to deworm your patients, and usually 3 days of, you know, nighttime albendazole whenever you're managing anemia patients should be a part of the prescription, irrespective of the age of the patient, but must not be missed in children for sure.
So thank you, Dr. Pandey, for reminding us about this. One question coming from Dr. Singhai. Many parts of North India, they suggest pomegranate juice for correction of
Okay.
anemia.
Yes. So same, it's a part of what we call it as a non-heme replacement oral iron therapy through the non-heme sources through the diet. There you have got green leaf vegetables, citrus, some of the citrus fruits we have, carrots, beetroots, all pomegranate you spoke about. Even broccoli is a good source. So this is a good replacement for sure.
Jaggery and chana. But
Jaggery and
pomegranate
chana is
juice,
also.
just ask them the cost actually. So if
Yes.
it is going to cost 300 rupees a liter, then we can just tell very politely, we can tell the patient that there are more economical ways of taking
Yes.
iron.
Yes.
But
Yes.
I think we should encourage patients because let us say the husband has anemia. The wife wants to do something for him. If the wife has anemia, the husband wants to do something. That's why he brought her to you in the first place. So find some
Yes.
economical ways, which might be, as long as patient doesn't have diabetes, jaggery and chana, using an iron utensil. Now, I know that iron utensil is not evidence based, but you are giving the family something to do. The family
Yes.
feels that they are part of management. So I think we should
Correct.
encourage that.
Yes.
We had said Dr. Mangesh last question, but more questions coming up. Dr. Ramakant
Yeah.
Sharma says hydroxyl iron, hydroxy form of iron. How is this
So
from
it's
an
in the sense, are you asking about, is it a ferromoxidol that you're asking?
yes,
Because it's same as, one of the IV forms of iron is ferromoxidol, and usually around 510 milligrams of IV, which is given over at least 15 minutes of the infusion, one dose is also used, which is also available. But there are all various intravenous iron preparations which are available. As far as oral hydroxyl form, there is no oral hydroxyl form which is available, to my
and
best of the knowledge.
yeah, Dr. Shagufta Yasmin sharing a best practice. Moringa leaves are very economical, and you can
Yes,
use them. You can use them for the management of diabetes.
right. But
Moringa,
Dr. Sanjay, I have a
yeah.
very, I would say, a very clear thought on that. Really,
Mhm.
at it's all with all due respects to all our sentiments to our, food and all that. But according to me, Prayal, it is very sometimes difficult to replenish the daily recommended nutritional or this iron supplementation through just food,
Mm.
because we are not very well trained as far as analysis of the various food contents and their micronutrient values. So to me, to explain to the patient is the simplest way. Is this that rather than confusing them, I always suggest them, take a pop up a pill, and that would suffice your basic need for the daily iron supplementation, which makes the therapy more simple for the patients and more cost effective also.
But we appreciate the thought process that Dr. Javed and Dr. Shigufta are bringing to the discussion. Dr.
Yes,
Javed's thought process is don't think of the individual alone, think of the community as a whole. So
community as a
simple
whole.
message. 7 days a month, 10 days a month, or 100 days a year, that is a good public health message. You share
Yes.
it with one lady, she will go and share with her friends, with her sister-in-law. So the community benefits.
And
When
what Dr. Javed is saying, Dr. Sanjay, anemia mukt Bharat, which has been, you know a
Yes.
campaign which has been run, is super successful, primarily because of this kind of initiatives. And the simple iron replacement initiated has really caused a good impact. So Dr. Ajay Khera speaks very well on this.
Hmm,
So he was one of the parts of anemia mukt Bharat abhiyan that the government has run.
hmm.
So yes, what you are suggesting is an absolute sensible thing. Sure.
When Dr. Vijay Pandey talks about deworming, what he is saying is that have a holistic health approach towards anemia. Don't think only of HB, think of the cause of low HB. And then
Yes.
when Dr. Chugufta says moringa leaves or drumstick leaves, what she's saying is that again you involve the family in care. It is not
Correct.
that the moringa leaves are going to replace the iron tablet or the iron injection, but they will complement. And you're teaching healthy lifestyle, healthy diet to your patients. So we do
Correct.
a little
Correct.
bit of everything together.
No, 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 no. I would say questions asked as far as healthy nutrition is concerned.
Two more questions. Dr. Anand Purandare says intramuscular iron. This also should be given in the hospital setting.
Preferably any parental iron, because remember, whatever the route parentally you are using, they can still cause anaphylaxis.
And
So
it can hurt
always
also.
be careful. And be little careful. Usually, even though it's a rule that we say that first dose did not cause anything, but that does not necessarily mean that the second dose will not harm. So be always careful. And there is no point, no harm in being careful, isn't it?
You have spoken repeatedly about the lack of advantage if we take hemoglobin beyond a particular level. But we welcome Dr. Shankar Dharmaraj from Karnataka, a very
Hmm.
avid learner. So welcome, Dr. Dharmaraj. And this last question, if you allow us to take, this is from Dr. Vijay Pandey again. Hemoglobin 18 grams. What are the differentials if the person is living in Ladakh and if the person is living in Mumbai city?
Actually, hypoxia, which is responsible. So, a chronic hypoxia because of any cause, or a high altitude living people, or patients of COPD, isn't it? Pink puffers is a typical, patient, those who are classic example, leading to polycythemia. So, any situation which can lead to polycythemia can be the cause of. But of course, when the patient is living in Ladakh, you probably will first think about the high altitude induced or a hypoxia induced polycythemia. In Mumbai, probably we'll be working out in on any other causes of polycythemia.
So high altitude, COPD, chronic smoking,
COPD is chronic
and I wonder
smokers.
if someone is doing a study or research on hemoglobin levels in NCR New Delhi, considering
Yes,
our pollution
yes,
levels.
I know.
It would be interesting if anyone has
Yes,
ideas to share now or maybe next week. And then polycythemia vera you have to work up if hemoglobin
yes,
is actually very high and you can't find
correct.
any other obvious reasons.
Yes,
So with this, I'd like to thank you once again, Dr. Mangesh. Thank you is a very
thank you,
simple, very
Sanjay
humble
Bhai.
word.
Thank you very much. Thank you very much.
You
Yes,
spent
it's
so
been
much time
always a
with us.
pleasure, privilege, honor, and also a matter of personal connect with you. And
That
thank you,
that
entire
connect
FDC
you have
team.
with everyone now who has logged in. So everyone has spent an hour with us,
Yes,
and
thank you
our
very much.
topic was iron talks. So thanks to
Yes.
everyone for logging in. Most of all, thanks to Dr. Mangesh for being with us, and thanks to our team from FDC, which goes out of the way to arrange this program every weekend for us. So I'd like, before we conclude, I'd like to hand over to Mr. Basu from Team FDC to give the vote of thanks.
So, Mr. Basu, before you say, let me again appreciate each and everyone, because as Dr. Sanjay has said, that that tells us that how much you love us, because you give your time to those whom you love. So we appreciate your love and affection for us. So keep on loving us, and thank you for making me learn so many things, because while preparing for this talk, I had to really go through a lot of things and try to find out how simplistically I can present to you. So thank you very much, everybody. I wish you all a very happy and a prosperous new year.
Thank you, Dr. Mangesh and Dr. Sanjay Karla, because when I was watching this entire session, we felt like a harmony. Actually, it's a symphony which was going on for last 59 minutes. That's because of two wonderful speakers today, Dr. Mangesh, as well as a wonderful moderator, Dr. Sanjay Karla. And I have heard one common thing which has come across from all the guest speakers which we had is that they have really uh, taken a time out from their daily busy schedule to go through this session which they have prepared and presented to us, and they in the way they have learned and they have also disseminated the knowledge. That has actually the wonderful outcome of this iron talk with Dr. Sanjay Khan. And as Dr. Sanjay Karla has reminded us on 14th of November, I personally know that through the email exchange of Dr. Om Gandhi, he is going to present something new to Indian doctors. So please log on 14th November, 9 p.m. Diabetes Health Check with Dr. Sanjay. With this, I thank Dr. Mangesh Triwaskar, who incidentally be from the same suburb of Dahisar, Mumbai, and Dr. Sanjay Karla with us. Good night. Jai Hind.
Good night.
Jai
Bye
Hind.
bye. Thank you
Jai
very
Hind.
much. Bye bye. Take care of yourself.